Thank you. I'm going to do a quick introduction, and then we'll let you take over. So, Dr. Carrie Reed, as you know, is an epidemiologist working at the Centers for Disease Control and Prevention, which is in Atlanta, Georgia, if you're not familiar. She is currently housed in the influenza division and has had a wonderful career working as an epidemic intelligence service officer and in studying severity of influenza and influenza vaccination in the U.S., its effectiveness and efficacy. She also consults on projects with the World Health Organization and has been involved with responses to the H1N1 pandemic and the H7N9 avian influenza outbreak in China, and most recently, very recently, with the Ebola response in Sierra Leone. She grew up in Arizona and did her undergraduate degree at the University of Arizona, and from there went to Boston University to do an MPH and her doctorate in epidemiology. So with that, we're, again, really glad you're here, and we'll turn the time over to you. Let's do a round of applause. It's good to be here. Thanks for having me today. As Chantel mentioned, I just got back from Sierra Leone actually on Thursday night, and so I had a weekend to recover and then fly out here. But we wanted to try and get it in before the semester ended this year for you guys. So what I'm going to talk about today is about some of my experiences and lessons learned from responding to public health emergencies in the international setting through a couple of experiences that I've had. So focusing on two different viruses, influenza and Ebola, both pictured up here. I work, as Chantel mentioned, in influenza in my normal job and have been there for about 8 years, since before the 2009 pandemic, working through that response, and then most recently on detail with the Ebola response. And so I'm going to talk a little bit about what are some of the general characteristics of responding to international public health emergencies, as well as some of the specifics that end up being a little bit different depending on what disease and what response you're involved in, and how influenza and Ebola are a little bit different. So just a little bit of background. So Ebola, you may have been reading a lot about it in the news over the last several months. It's a virus that was discovered in 1976 near the Ebola River in what is now the Democratic Republic of the Congo, at the time Zaire. It's a viral hemorrhagic fever. There are several different viruses that cause this type of disease, characterized by fever and unexplained bleeding, leading to shock and ultimately organ failure. And it's fatal in about 50 to 90% of the cases, depending on the situation and the particular strain. There have been sporadic outbreaks throughout Africa since 1976. There's a picture here indicating where some of the outbreaks have been identified since then. Generally in isolated villages, generally fairly small, at most about 150 to 200 cases. And then in March of last year, there were initially some news reports that identified that there were a cluster of hemorrhagic fevers in Guinea. That at the time, there are several viruses that cause hemorrhagic fevers, and so at the time there was some confusion over whether it was actually caused by Ebola or something else. There were some few CDC people that went out in March to help investigate some of the early cases. And then over the course of March to July, in kind of small numbers, there were Ebola cases that were confirmed in Liberia, in Sierra Leone, both of which border Guinea, as well as in Nigeria from a traveler who had recently traveled from one of those countries. And so things were starting to pick up. More public health agencies and more CDC people were getting involved. And in the beginning of August, the World Health Organization declared the outbreak a public health emergency of international concern, or a FAKE. And this is a relatively recent designation that was part of a set of international health regulations that were developed by WHO and adopted by member states in 2005. Mostly in response to the SARS epidemic, to try and avoid some of the problems that happened with that and the lack of response and timely awareness of that outbreak. These new regulations were developed in 2005, and WHO declared that status as a public health event of concern in the beginning of August. So now switching over to influenza. This is my normal job. I spend a lot of time doing research on flu. And this is a virus that infects the respiratory tract of both humans and animals. It causes fever, cough, sore throat in general, but there can also be very severe complications leading to hospitalization and death. It's spread via the airborne and droplet transmission routes, so coughing, sneezing are generally the routes of transmission for flu. There's rapid mutation of the virus, which contributes to having annual epidemics. We call this antigenic drift. The virus changes just enough that next year or the following year, there's not enough immunity left in the population to recognize that virus, and you get a new outbreak of flu. It's also why we have to make new vaccines for flu every year, because the virus is constantly changing and constantly evading what immunity there might be in the population. Of a bigger concern is that there can be viral reassortment between different strains of influenza. Influenza viruses infect people. They also infect birds. They infect mammals like pigs. And each species tends to have its own types of flu viruses. But when they happen to co-infect the same animal, usually pigs, those genes can reassort, and you can get new flu viruses that have never been seen before in any of the species. And so that's what this graph is showing. Pigs tend to be a very effective mixing vessel. They can be infected with lots of different flu viruses. They can be infected with human viruses and bird viruses and viruses from other animals. And when they all combine in a pig, those flu viruses can swap genes. You can get a brand new flu virus that's never been seen before, that the human population doesn't have any immunity to, and that can result in a pandemic. So in 2009, that's exactly what happened. In the US, I was working in the influenza division at that point, and remember when we got the call from California that they'd identified 2 viruses that were testing positive for flu, but couldn't be typed by any of their normal methods. So they sent them to the CDC, and our lab sequenced the viruses, and it was a new virus combination that had never been seen in humans or in animals before. But it was related to swine influenza viruses that we knew about. And so we were doing an investigation thinking that this was a swine virus. We had been noticing an increased number of detections of swine viruses in people in the recent years. And so we wrote this notification in the MMWR, which is a CDC publication updating on health events, and continued our investigation looking for pig exposures that we usually find when we find these viruses unexpectedly in people. But after working on the investigation for about a week, there still was no link to swine. There were no county fairs, there were no petting zoos, there were no association with pigs. And by the end of that week, there were now 10 cases in 6 different states, so making it unlikely that they were all getting it from the same source, that there seemed to be something else going on. And at the same time, we were getting reports of severe respiratory illness in Mexico, that they were seeing an abnormally large number of hospitalizations for respiratory illness, severe respiratory illness and pneumonia, including deaths, that they had notified WHO of. And shortly we were able to get viruses from patients in Mexico, and they were the same viruses that we were finding in these kids in the US. And so the CDC began to do a much larger investigation on what was going on. And about that time, when we identified that the viruses in Mexico and the viruses in the US were the same, again, the WHO declared this fake, the public health incident of concern, international concern. And this was in response to the fact that we had demonstrated that there was human-to-human transmission of this new virus in the US. And over the next several weeks, we continued to see large increases in transmission throughout the US and began our public health response in the US. By June, there had been evidence of sustained transmission documented on multiple continents, which met the criteria for WHO to declare it a pandemic and expand the global response to the situation. So what does that mean, the public health response to these situations? So in the US, at CDC, we have an emergency operations center that's shown up there on the top left of the picture. It's a central command center at the CDC that is activated during public health emergencies, where a core group of responders can be together in that command center, can have easy access to each other, to leadership during meetings, and to the central response organization. And on the right, there's a series of levels of activation of public health response, depending on the nature of the emergency, from level 1 being the greatest to level 3 being the lowest. And at level 3 incidents, these could be international, they could be domestic, they're relatively small. They can be managed usually within the program at CDC that deals with those, with just a little bit of extra resource from CDC. Level 2 is slightly more, where you may need to bring in other people from CDC to help out with those investigations and those response. And then level 1 is the highest level of response. It's only been activated at that level 3 times, one for Hurricane Katrina, one for the H1N1 pandemic in 2009, and then this past year for the Ebola response. So the highest level of activation, the full response structure, and bringing in hundreds of people from throughout CDC who may not be working on that disease area for their primary job, but are brought in to help out with that. And so that's kind of how I got involved in the Ebola response. They've had many hundreds of CDC employees from all over the agency who are trained in field investigations and outbreak response and public health response to be involved in these situations when they need the extra help. And the structure that we use was developed by the Department of Homeland Security there at the bottom. After the September 11th attacks and the anthrax attacks in the US, as a national incident management response to try and coordinate efforts between agencies and have a structure for how that might work within agencies and allow to work most clearly between agencies and have a focused response. And so this is a flow diagram of the incident management structure that was refined over those years and put in place during the 2009 response. And it may be hard to see in the back, but the general idea is that there's an incident manager at the top who is generally a subject matter expert in that field, who oversees the response at CDC. They're brought into that position for the duration of the response, and they manage the entire team, which is a very large team comprised of different groups here. So there's, on the left, there's a joint information center, which is all of the communications, all of the coordination of all printed materials, all guidance that goes on the website, all publications that come out, all public health messaging, everything. So all of the communications around that are managed through that side. Then there's the general administrative response functions that are very important in a public health response. Operations and planning, finance, logistics, all of that is, again, a great number of people that are brought in to coordinate the response in all of those aspects. So that's a very important part of public health response. And then at the bottom, or the foundation of the response, is the scientific programs that are involved in contributing information to leadership and to decision makers. So down here in the bottom, the Epidemiology and Laboratory Task Force, that's where I fit in to this infrastructure as an epidemiologist. There's also a group that does community mitigation, trying to decide what recommendations about control in the community, about school closures and limiting mass gatherings and all of those interventions that might be needed at a broad level. medical care and countermeasures, so assisting with any medical care issues that may be needed to help out the healthcare infrastructure, the vaccine task force, and the state coordination task force. So in the US, coordinating our partners in various states. And then there's another box that's not shown on here that is the international coordination task force. So the same idea as coordinating our domestic partners, but also coordinating all the international partners in the various countries that are being assisted by CDC as well. And the goal of having this in a very organized and structured framework is to best be able to deal with all of the challenges that come up during a public health response. And there are many, including in many international settings, and even to some degree in the US, there's limited public health infrastructure. In many international settings, there's just not a good public health infrastructure in general. And in some parts of the US, there's just not enough to be able to respond to these large-scale situations. The healthcare systems get overburdened easily. So in the top, the picture's very dark, you can't see it, but it's a makeshift Ebola treatment center that was set up very early on in Guinea, which was very characteristic of a lot of the treatment centers throughout the area in West Africa. Toward the end of last year, they started to get some more well-developed treatment centers set up in many of the countries, but for a long time it was these makeshift centers that were set up around an existing government hospital or other facility because they just didn't have the capacity to be able to manage and treat patients at the levels that they were seeing. And this bottom picture is in the US. So during 2009, during the H1N1 response, because of the high incidence of cases throughout the US, there were many places, especially in larger cities, that couldn't manage the capacity at their emergency departments and in their healthcare, and had to set up these tents in the parking lots of emergency departments to be able to deal with the overflow of that. And so in these situations where you've outstripped your capacity to manage cases, you have insufficient treatment centers, beds, medical supplies, PPE, and the public health response, part of the public health response is to work on making sure that those supplies can be acquired and be sent to where they're needed, and coordinating that response as well. So there's a lot of public health needs that happen in these situations. There's a need for surveillance and monitoring to assess the situation and to follow up how it's progressing. Field investigations to investigate specific aspects of the disease and to learn more about how it's transmitting and how serious the disease is and what interventions on local levels might be effective. Laboratory support. This is a picture of our influenza lab in 2009 with specimens being shipped from all over the US and all over the world, kind of overwhelming the lab and the ability to have a place to store everything. They got piled up in the foyer of our flu lab. Assistance with providing adequate medical care when the existing healthcare capacity is overwhelmed. Recommendations for disease control in the community. Communication and education. Provision of supplies, could be through stockpiles, could be through acquisition of large numbers of supplies and PPE and medications to distribute where needed. Food, water, sanitation is big issues, especially when you are having these situations in the community where you might be implementing community measures like quarantines or isolation, making sure that people have adequate food and water to be able to follow those recommendations. Border protection, and then research as well. There are situations where specific research questions may need to be answered. That's actually what I ended up working on in Sierra Leone. The CDC is working on doing a vaccine trial in Sierra Leone for one of the candidate vaccines that's been under development for several years but hasn't yet been tested in large numbers of people in areas where there's Ebola circulating. And so I was working there on setting up helping to set up the vaccine study in Sierra Leone. And then another big public health need is efficient use of stakeholders. So this is an example of probably not the entire universe of organizations and agencies and NGOs that were involved in the Ebola response. These are just some of the ones that I interacted with in the 6 weeks that I was in Sierra Leone. So a lot of different national and international governmental organizations, non-governmental organizations, faith-based organizations, a lot of different groups that are involved. And the bigger the response, the more agencies that are involved, and the more confusing it gets as to who is responsible for what aspects of the response and who should be doing what, and whether anybody is doing what needs to be done. And so one of the things that the US CDC did in Liberia, especially when they were there very early on, was try and put this infrastructure in place. So again, this is that incident management structure that I talked about before for H1N1, was putting something like that in place in country to help organize this response, to help identify what the needs are, and then to work with all of these partners to try and identify which boxes those organizations might best be able to contribute to and help with. So again, epidemiology and surveillance being a key aspect of that, contact tracing, laboratory, social mobilization, which is community outreach and education, and case management, getting cases into care early, getting them appropriately treated, and getting them the support, the psychosocial support that they need to the cases and to the family members during this time. And then finally to have appropriate burial for cases, given how infectious people with Ebola can be even after they've died. And so there's been a lot, you may have seen in the news, there's been a lot of discussion about how much transmission happens with traditional burials and the washing and the touching that's involved in these traditional burials. And so having a group that was really dedicated to getting people identified and the bodies picked up and buried in a way that is safe and that doesn't contribute to transmission is a huge part of the response internationally. And then another big challenge is that the response needs to adapt to each unique situation. So every event is different. Just because we did something a certain way in 2009 for the influenza response doesn't mean that's necessarily the best way to respond to Ebola. And so I'm going to go through some of the unique situations that have differed between the Ebola response and the influenza response. So I want to start out with an example. So this is an illustration. This is some basics about Ebola and influenza that contribute to how different the epidemic has been and how different the response needs to be to these two pathogens. So the first thing is the basic reproductive number, or what we call an R0. And this is the average number of infections that an infected person will leave in the population. So for Ebola, it's about 1.6 to 2. So on average, a person may infect 2 other people, or not quite 2 other people, during their infection. And it's relatively similar for flu. So not quite 2 people on average each person infects. This is very different than something like measles, which is often over 10. So a case of measles may infect 10 or more other people. So influenza and Ebola are fairly similar, not highly infectious on average. But there's a big difference in the second characteristic, which is the generation time of the infection. And this is the time between one case to the next case. And this has a big impact on disease control and the mechanisms and the efforts that you would put into disease control. So for Ebola, the generation time is about 14 days. So between one person getting infected and the next person getting infected, it takes about 14 days. And that's because Ebola symptoms don't manifest themselves very early on in infection. And people with Ebola aren't infectious until they start having symptoms. So it takes a while between one person getting sick and then the next person getting sick. But for flu, it's very fast. In 2 or 3 days, you're already on to the next generation of transmission. So even though one person may only infect 1 or 2 other people, that happens very rapidly. And so you can very rapidly develop a large number of people that have the infection. An additional complication with influenza is that people can be infectious before they have symptoms. So the idea of isolating somebody to prevent onward transmission is very difficult because they could be spreading the disease before they even know they're sick. And that's not true for Ebola. So the idea for Ebola is that you could identify a contact who may be infected, isolate them quickly, and remove them from having any opportunity to transmit the disease any further. There's differences in the route of transmission. With Ebola, you need to have very direct contact with blood or body fluids to become infected. And with flu, that's not the case. You can get it through coughs and sneezes and virus being in the air after somebody's been there who's infected. And then there's a very different risk of fatality if you get infected. So with Ebola, as I mentioned, it's over 50%. In some cases, 90% of people who are infected die after they get infected. And with influenza, in the case of H1N1 in 2009, the risk was quite small. Less than 0.1% of people who were infected ended up dying. Most cases were relatively mild and self-limiting, and there wasn't any further complications from that in most cases. So this is an example. So when I was in Sierra Leone, I was in a district about 3 hours away from the capital, working with the public health system there and trying to get this vaccine study set up. And there was a village very nearby that had an outbreak while I was there. The village was about 900 people. And during that time, there was a case that became sick in Freetown, in the capital city. And when he started having symptoms, he suspected that he might have Ebola and didn't want to be isolated there away from his family. So he got as much money together as he could and hired a taxi to take him back to his village out about 3 hours away, near where I was working. And the family took him to a traditional healer, and there was the traditional washing of the body, and unfortunately he died, and they did some preparations to the body after he died, at a time when somebody with Ebola is highly infectious. And so just from that one case, there ended up being about 60 cases in the community. About 40 of them were directly linked to contact with him through the traditional healer, and then about 20 more that were infectious from those initial cases. So all in all, about 60 cases in that population of 900, and 40 of them ended up dying. So very, very devastating to individual communities if there's an outbreak in the community. If you took that same community and overlaid what you would expect from influenza, you get a very different story. So based on those characteristics I mentioned of the 2009 H1N1 virus, in those 900 people, you would expect to have many more cases, about 180. But of those, you may not even have one death. And then if you look at the 1918 influenza pandemic, which is thought of as kind of the worst possible public health emergency worldwide that you could have, you might have about 300 cases, or in some cases in 1918 in isolated villages, they had almost 90% attack rate, so maybe 800 people would become sick. And the death rate was higher for 1918 than for what we've seen recently with influenza. Maybe you would get about 8 or 20 deaths, but still less than Ebola. So there's a big difference on the local scale and the type of local response that you would do for Ebola versus influenza, where with influenza you have many, many more cases, but most of them end up being milder and self-limiting, versus Ebola, where you have fewer cases, but those cases are extremely severe and very devastating to the population. But if you take a step back from just a local community and step back to the global picture, in the past year, so now that Ebola, this outbreak has been ongoing for about a year now, and it's still been largely limited to this relatively small section of the world. So these 3 countries have contributed most of the approximately 25,000 cases. There have been a few cases elsewhere in the US, as you've, I'm sure, heard about in the fall, and in Nigeria and Senegal and some other places, but a handful of cases. Most of them have been limited to this area. And it's been very devastating on a smaller scale, but in a global scale has not been has not been devastating outside of this region. In contrast to, there we go. So this is in 2009, this is the H1N1 pandemic. So in the first probably 7 weeks of the pandemic, there was virus detected in over 100 countries in every inhabited continent of the world. So the virus spread very fast and very far. And ultimately, contributed in 1 year, so again, equivalent time that we've been seeing Ebola, to about 284,000 deaths in the global population. And for the 1918-1919 pandemic, again in 1 year, just 1 year alone, accounted for over 40 million deaths in the world in just 1 year. So we have these two different situations where you have Ebola on a small scale is absolutely devastating in a way that flu is not. But when you think about the impact to on the global scale, the global economy, the global public health infrastructure, influenza has the capacity to be extremely devastating. And so the response ends up being a little bit different. And the goals of the response end up being a little bit different. So if we think about what is the goal of the Ebola response, this is a slide that our country director puts up all the time. This is the goal, 0 cases, eliminate the disease. That's the goal of the public health response. Find every case, extinguish chains of transmission, and get rid of the disease. And you stop transmission through case identification, contact tracing, infection control, and then a vaccine if it's available, which there isn't one yet, and that's why we're starting to work on these vaccine trials. And then in the meantime, improving patient care as much as possible, trying to manage these very medically complex cases, trying to limit fatalities as much as possible for a disease that kills so many people that are infected, doing as much as possible to limit that risk of fatality. And there's also some ongoing research in drug trials that have been started in these countries. So this is what the basic public health response is for Ebola. This is contact tracing. You identify a case, you find all of their contacts. You follow them up to see if anybody gets sick. This person got sick, so then you identify all of their contacts, and you find that one of their contacts got sick. So you identify all of their contacts. One person got sick. Then you identify all of their contacts until you get to the end where there's no more transmission. You've successfully extinguished that chain of transmission. The faster that you can identify contacts, isolate them, and monitor them for symptoms, the better off that you are at stopping these chains of transmission and extinguishing any more Ebola in the community. And that's what the response is over and over in Liberia, in Sierra Leone, in Guinea, is finding cases, finding their contacts, isolating people, and getting them into treatment quickly. And it's been very successful. The disease was very out of control in the fall and early winter, peaking at its worst in about December and January. But since then, it has gone down. Liberia got down to 0 cases a few weeks ago and then got back up to 1 or 2 and are working on getting back down to 0 again. Sierra Leone, just in the past week, had their first day with 0 cases anywhere in the country. They've since had a few. It's a bumpy road getting down to 0. Guinea is still having ongoing transmission. There's still a lot of public health work in Guinea going on trying to do this. And until every chain is extinguished, the public health response doesn't stop, because as long as there's one case out there, this can all start over again. For a pandemic, the goals of the response are very different. We never expect to find every case. Most cases are mild. They'll never go to the doctor. We'll never know about them. We can't possibly identify all of them and their contacts. We're never going to stop transmission until it kind of dies out and goes away on its own. The goals of the public health response to a pandemic is to mitigate disease in the population. So it's delaying the outbreak peak long enough to hopefully get a vaccine developed and out to the population to prevent disease. Decompress the peak, so move from this unmitigated peak to bring down that peak, to preserve the healthcare resources that you have, to not overwhelm your hospitals, to not overwhelm the capacity of the healthcare system to respond. And then generally to diminish overall cases and health impact. We never expect that we're going to get to 0 to identify every case, but we can do whatever we can to reduce the impact that the disease is having in the population. And in order to do that, you have to make some decisions about what interventions you're willing to recommend in the population. And that is ongoing discussions at the leadership level in CDC, is what are we willing to do, what kind of interventions, and how stringent are we willing to be to bring down and mitigate this peak during a pandemic. There's a lot of discussions about what can you do in the community. Can you close schools? Can you cancel mass gatherings? Can you implement quarantine and isolation? But those all have secondary consequences. There's consequences on somebody's individual liberties. There's consequences on keeping kids out of school and parents having to figure out what to do with kids when schools are not open for months at a time. And so there's a lot of discussions about what would make you decide to do something more extreme. And there were some decisions about that before the pandemic, which didn't actually work out as well as they had hoped. And so since the pandemic, one of my projects that I've been involved in is working with our group and with our agency to try and come up with a better framework for making recommendations and what our public health response framework is. And as an epidemiologist, my bias in that has been that we really need to emphasize this data-driven assessment and response, that there's not going to be a one-size-fits-all response. We need to understand the situation that's actually happening. Is this a mild influenza pandemic? Is this a severe influenza pandemic? Is this a Ebola outbreak? If so, how widespread? And what is the context? So we really need to collect data. And as an epidemiologist, that is what I do, and that is what should be the foundation of making any kind of assessment, making any kind of decisions about recommendation and communication. And so we've been working on that for the last several years. There have been some just recently updated preparedness and response frameworks out of that work at CDC for influenza pandemics. I think there's some ongoing work thinking about how things have gone for Ebola and some post-event planning for that as well. WHO, likewise, has been working on incorporating that into their framework as well. And I've been working on coordinating with them during their process of trying to establish, again, a data-driven response framework that can be set up in advance of the next situation to try and take into account the epidemiology of the disease, the severity of the particular pathogen, as well as the social context, the economic context, and all of those other factors that can really play into how a disease event unfolds across the global stage. And really thinking about these critical questions about how all of these factors interact to create the scenario that you might be responding to in one of these events. That there's not just one thing that you need to look at. You need to look at characteristics of the disease organism, characteristics of the population, the human population, in terms of genetic factors and the ecology of disease, the social, political, and economic factors, as well as the physical environment factors. All of these contribute to how the disease manifests itself in the population, and all of them should be taken into account during the public health response. So there's a part for many different groups to be playing in a public health response, and the more that that can be worked out in advance, the more that all of these partners will understand how to work together and how to contribute to an efficient public health response. This is an example of some of the things that we did at the beginning of 2009 to try and provide some data foundation, evidence-based foundation for the response. Lots of different investigations, lots of different analyses of our surveillance data, and a lot of different laboratory investigations and other investigations to try and provide that evidence-based foundation for the response. One of them was looking at severity and disease burden. So what age groups are most affected, and how great is the risk of hospitalization and death? And so this was work that we started in May after the beginning of the pandemic and continued to update for leadership throughout the process. So that was a very important part of the response, was providing this context to leadership for their decision-making. Looking at transmission, when does transmission happen, and how long would we need to close schools if we close schools? This was a very big question, a very lengthy discussion at leadership. And so doing some studies with some of our academic colleagues to try and figure out what is the probability of transmission on different days. And so this is days symptom onset, and about 80% of transmission happened in the first 2 days of illness onset. So unless you're identifying people very quickly in their disease, transmission has already happened. Isolation is not going to be effective. But since most transmission happens within the first few days, if you did need to close schools because of an outbreak in your area, you wouldn't need to keep them closed for very long in order to reduce transmission in the community. So that was a very reassuring finding that helped decision makers decide how to respond in the community and what recommendations to make. And also, where is transmission happening? Is it happening in a house, in classes, in grades, in schools, communities? Doing some analyses on this helped us decide where to focus interventions. So having evidence on that front can also be contributing to the response. For Ebola, trying to identify what's contributing to transmission. There were some early studies finding that the transmission was very clustered, that it was linked primarily to healthcare exposures and to funerals. And that really helped focus the response on what can we do to reduce transmission in healthcare facilities. How can we best intervene in the community to help reduce these unsafe burials and get people buried in a way that is culturally sensitive but also can prevent onward transmission. Population mobility and understanding how people move is also incredibly important to responding to these disease outbreaks. This was a quote from WHO in July 2009, that in past pandemics, flu viruses have needed more than 6 months to spread as widely as this new virus did in 6 weeks. And there were several analyses linking that to air traffic patterns, and that understanding that the population is very mobile now and disease spreads very rapidly. And understanding how populations move and how disease spreads is very essential to the response. Also with Ebola, the same issue, just on a more narrow geographic scale. So there's very porous borders between these countries and a lot of mobility within the region. This analysis at the bottom here, this map, was actually done using anonymized cell phone records to see where people's cell phones moved during that time period. They could track movement patterns within the region to try and predict what areas might be most affected next based on how people move within that West African region. And so analyses like that were really useful at helping to identify where the problem areas might be and where the next areas of focus need to be. Where can the public health resources go to identify where the next hotspots might be? And all of this information has really, in the past several years, gone into improving disease modeling and forecasting for public health response. And this has been a large growing area of work for public health response, which is, can we take the data that we have early on in an outbreak and what we know from the biology of the disease, and can we predict what's going to happen in the future to help us guide our public health response and to help us focus our efforts? So this top graph is an analysis from the early data from the Ebola response. Based on that early data, kind of forecasting what might happen if interventions started in September versus if those public health interventions were delayed until October or November, getting people on the ground in those countries to be able to implement these recommendations, and how the course of the outbreak might differ depending on whether disease interventions were delayed. This graph is a graph of flu forecasting. There's also an increasing effort at developing models that can predict where flu is going next. And so our group at CDC has been hosting a competition with different academic groups to improve efforts at disease forecasting so that we might be able to better use that evidence and use that early data from these investigations to try and help our public health response focus on the areas where it's needed the most. So just to sum up, there are a lot of challenges and complications to doing these investigations globally. There's a lot of players and a lot of resource limitations, but really moving towards these evidence-based recommendations and evidence-based decision-making processes can really help focus the response in an appropriate way for the disease and the situation that is occurring at the time, and recognizing that not all public health responses are going to be exactly the same, and having people who are well-versed in the subject matter and in the analytic techniques to be able to analyze that data are really important in a public health response. And then having some framework and some plan in advance is really necessary for getting these responses done in an efficient way. It prioritizes the data and analytic needs that you're going to need to make decisions. And then it also can get partners together in a way that is a much faster and more coordinated response to these public health situations. So thanks.
We do have a few minutes for questions. I know some people have to run to class. I just want to make sure before you go that you fill out that little sheet you were handed before you came in. That's important for our record keeping. Okay, and if you're able to stay for questions, please do. That was really fascinating.
You showed the slides of like how infections spread across countries and continents. What's the hardest thing, or is there any difficulty in getting different governments to cooperate?
I don't know that there's a... So the question was, based on showing how disease is moving across the world, is there challenges in getting different countries to respond and to share information and be involved? And that is probably the biggest issue is kind of getting cooperation from different government partners. We've spent a lot of effort on the flu side in the past probably 10 years or so, developing relationships with countries around the world so that we have that existing relationship in place and existing surveillance and infrastructure in place that we can draw on. But some regions of the world are much more difficult. So there's been a MERS coronavirus outbreak that's been happening in the Middle East and has been notoriously difficult for CDC to be involved in the public health response because Saudi Arabia and some of the other countries haven't been terribly welcoming to the US participating in that response. So there still is a lot of international diplomacy issues that also have to happen for these public health responses to be effective.
I was just wondering if you, had any thoughts, or if there was any, like, what is the main difference between, like, Ebola and influenza that causes them to have, like, such different effects on, like, a widespread scale internationally?
It really is the biology of the disease. And I think those really basic properties of how a disease spreads and how quickly it can spread make a huge difference in what you do and how you respond. And so I think in every situation, Ebola is just going to be different than flu because it is very different than flu. But even within influenza, there's enough variability that the way people perceive and respond to it can be really different as well. You know, for something like Ebola, when you get it, the disease is extremely severe. And everybody that you know who gets the disease gets extremely sick, gets hospitalized, and most of them die. And people respond differently to that than something like flu, where, oh, everybody gets the flu, and I knew 10 people who got it, and they were all fine. And so people's reaction to that is a little bit different as well. And what people are willing to do to prevent disease is different. You know, people would be more willing to give up some personal liberties if they thought everybody they knew who got infected with Ebola was going to die, versus, well, I know everybody, I get the flu all the time and I'm fine. I don't want you to take away my personal freedoms. So there's there's that limitation as well.
Thank you.
Thank you for a wonderful lecture. I was just curious if you touch upon for a second what your role was in Sierra Leone last week, and also how you were received by the local teams as well as the local population, if you had any security concerns per se, anything like that.
Yeah.
Thank you.
So I was working on our vaccine task force, so working to set up a vaccine study. So this is a country that doesn't really have a research infrastructure. And so working with the local public health response, working with hospitals, working with infrastructure there to try and figure out how you would do a vaccine study in a country that doesn't have much of a research infrastructure. So I was out in one of the districts, I've embedded with the public health response and working with the hospitals at trying to figure out the logistics of getting ready to implement a study. And so we were actually very well received within Sierra Leone. I think there's been some resistance in Guinea to some similar work, but I think there's a very large sense in Sierra Leone that they are really excited about building up their infrastructure and working with CDC. And so we had some local staff that were hired to help us. We had some pharmacy students who'd passed their exams but haven't graduated yet because school's been closed for the last 9 months. So a couple of them, there were some Peace Corps employees who don't have jobs right now because all the Peace Corps volunteers have been removed from the country. And so they worked with us as cultural liaisons. And then we were embedded with the surveillance and epidemiology infrastructure that really has strengthened and improved since the start of the outbreak, and they have a fairly well-functioning response in that village that I was in and that city that I was in. And so really working with them on the day-to-day of just setting up a foundation for how you would start a research study in the midst of a public health response.
Thank you, Carrie. I just have a question regarding your experience in working in these various governments, working within our own government. It would have seemed that in the process of trying to communicate these risks, some of these concerns and these issues, that politics and policies are in the way sometimes. What lessons learned have you had that you'd offer that could be helpful?
Oh, politics and policies. Yes, it's difficult. Even in Sierra Leone, there's been, well, even between the three countries, the affected countries, there's been a big difference in how responsive the government has been. So I think Liberia was the most responsive and most rapidly responsive to having CDC involved and other public health agencies involved very early on and moving forward with that. There was initially some resistance in Sierra Leone, but I think just the devastation that was there was so obvious that political will kind of ended up coming on board. There's been still a lot of resistance in Guinea. There's a lot of historical resistance to kind of outside influence as well as even internal government influence. And so that's probably one of the reasons that the outbreak is still not under control in Guinea. But in other situations, just working, I think, with governments and developing those relationships before an event happens is probably the best way to have those relationships work well after the fact. So I can speak from influenza. We've spent a lot of effort in the last 10 years building up relationships with different countries in Africa because we recognized that there was a resistance on the side of the political will and just a basic lack of awareness and appreciation for influenza. And so little by little, working with ministries of health and then the government, political government, to start small and set up some basic surveillance in their country to try and demonstrate that, yes, influenza is a problem here, and here's how we can work with you. So that when events like this happen, we have existing partnerships in place. We didn't have partnerships in Sierra Leone at the time, or Guinea, but the CDC is now setting up a country office in Sierra Leone so that we can try and have those ongoing relationships within those governments as things go forward. I can repeat it if people can't hear.
It gets recorded though here.
Oh, okay.
It's being filmed, if you don't mind. Sorry. Thank you.
So you discussed two different viruses today, Ebola and influenza, and one spreads easily but isn't very lethal, and one spreads with difficulty but is. If there were a virus to emerge that combined those two things, spreads easily and was lethal, beyond like just shutting down borders, what sort of response is possible to that? And do you think the international community is ready to respond to something like that?
So that is the big outstanding issue, I think. I think I have a slide. So this is some work that we did kind of as we've been working on developing our response framework for influenza. And so there's this idea that both the incidence in the population, so this ease of transmission, is important, as well as the severity of the disease, right? So these are relatively broad scales that have been experienced by flu in the past. So case fatality ratios up to 1% or over 1%, which seems small, but for flu is actually quite severe. So you can have these situations where this is like the 1918 pandemic, where if it happened again, a virus of that severity and that transmissibility in the population, you'd have close to 1 million deaths in a year just in the US population. But there's this other area down here where disease is severe, so Ebola-like, or not even to the point of Ebola, but severe, but transmission is relatively low. And I think this is the unexplored space still, the point that you bring up, these high consequence pathogens that aren't terribly transmissible, but maybe a little bit worse than Ebola is. And I think we don't yet have a good idea of what we would do in that scenario. And so that's what a lot of the ongoing planning is working on. We've had experience in these kind of other realms, but we haven't really had a good experience in that realm. But there's the capacity to be quite devastating. And I think trying to figure out at what point would you recommend these much more stringent, much more restrictive public health recommendations to really try and curtail transmission as much as possible, because we don't have the capacity at a global level or even a national level to deal with something that's just a little bit worse than either of these situations right now. So I think that's the ongoing area that people are really interested in right now, is what is the threshold for these more restrictive public health recommendations to try and reduce disease transmission in those situations.
So follow up to that question, how could we expand that threshold?
That is one of those political will and social will questions that is very difficult. And I think there's a lot of the more of public health education and anthropology side of things that are, I think people are recognizing that more and more needs to be engaged in these public health responses, is trying to understand behaviors and what behaviors are what interventions would be tolerable to people, and how you can communicate the need for things that are a little bit more stringent. I was talking to some coworkers during my time in Sierra Leone, and so when you have these houses that have a case, the house gets quarantined, so all the household contacts get quarantined. And the quarantine is basically they put a rope around the whole house to indicate that house has been quarantined. And yes, there have been some people who've escaped from quarantine in the middle of the night, but for the most part, people are compliant. They sit on their front porch and they watch the world go by while they sit behind their rope in their house. And it's sad to walk by and to see them so restricted, but you know that it's necessary to monitor them and to identify who gets sick and get them into treatment quickly. But I think that wouldn't be tolerable in a lot of situations, and I don't know that it would be tolerable in the US. There's a lot of concern about personal liberty and personal freedoms, and you just put a rope in front of somebody's house and said, you can't leave your house for the next 21 days, would that be tolerable? How much outcry would there be? How much political leverage would we have to be able to implement that kind of public health intervention in the U.S. or in a different population? So I think there's a lot of education, a lot of communication, a lot of this more anthropology side of things to try and figure out how you would implement more restrictive public health interventions if needed, and what would you need to do to get the public will and the political will behind you in terms of your public health response.
Well, thank you again.